Hello. Nice to see you. Welcome to our next session, which is on congenital heart diseases, tumors, and pulmonary hypertension. I have the pleasure of co-chairing this session with Dr. Laskari and Dr. Mavroyeni.
Nice meeting all of you.
Instead
I don't have the chance to see you every day, so I enjoy the moment. Welcome, please.
Great. So Dr. Pusparajak will not be with us, but yeah, I know. So I will invite Dr. Laskari, our first speaker, who is specialist in fetal cardiology and pediatric cardiologist as well, who will present a very interesting topic: cardiac masses and tumor in children. Interesting and challenging, not only from diagnostic purposes, but also from technical purposes as well. So, Dr. Laskari.
Thank you so much. Thank you, everybody, for inviting me. And as always, I'm giving this talk about tumors and cardiac masses in children, which are very, very rare, as we always know. Okay, so can you see my presentation?
Okay.
Is that, can you see my presentation? Yes, okay.
Yes.
So my talk today will be about cardiac masses and tumors in children. Cardiac masses and tumors in children are very, very rare. They could be benign and malignant. The estimated prevalence is 0.002% to 0.3% at autopsy cases. But even benign cardiac tumors can exert significant clinical effects by altering cardiac hemodynamics and by acting as embolic and arrhythmia substrates. Cardiac tumors in children consist of both primary and secondary tumors, with the majority being benign primary tumors. Primary cardiac tumors in the pediatric population have an even lower prevalence of 0.0017% to 0.28 at autopsy studies, and an incidence of 0.14% during fetal life. The most common malignant primary cardiac tumor in both children and adults is sarcoma. Metastatic cardiac tumors, which occur via either direct extension or hematogenous spread, occur less often in children than in adults and include sarcoma, lymphoma, testicular cancer, and Wilms tumor. There are also some entities mimicking cardiac tumors, like thrombus, pericardial cyst, and congenital cardiac aneurysm or diverticulum. In children, cardiac tumors, the most common of them are rhabdomyoma, fibroma, teratoma, myxoma, and there are some other benign tumors like hemangioma, lipoma, Purkinje cell tumor, or fibroelastoma. As I said before, the malignant tumors, the most common of them are hemangiosarcoma or rhabdomyosarcoma. The majority of primary cardiac tumors in children are benign. Rhabdomyoma and fibroma are the most common, 80% of all cases of all cardiac tumors in children. In the fetus and neonate, teratoma and rhabdomyoma are the most common cases, accounting for more than 70% of the cases. However, in adults, the most common primary cardiac tumor is myxoma, which is very rare in children. The symptoms, the cardiac tumors can present with symptoms such as, depending on the tumor location, the tumor type, and the patient's age. The most common symptoms are cardiac murmur, arrhythmias, cyanosis, congestive heart failure, respiratory distress, and sudden death. The diagnostic approach consists of chest X-ray, ECG, echocardiogram, which actually is very important, and of course cardiac MRI, Holter monitor, cardiac CT sometimes, and very rarely cardiac catheterization. Typical locations of the most common cardiac masses are the ventricles, usually the ventricles in children. In the ventricles, we can see the most common tumors such as rhabdomyomas and fibromas. In any other chamber, we can see lipoma, hemangioma, rhabdomyosarcoma, and metastasis. In the pericardium, we can see pericardial cyst or metastasis, and also teratoma. And the right atrium, angiosarcoma and lymphoma. And usually in the valves, in the valve tissue, we can see fibroelastoma and vegetations. In the left atrium, we can see thrombus, myxoma, fibrosarcoma, osteosarcoma, and other sarcomas. Cardiac MR imaging is the modality of choice for further characterization of cardiac masses, especially in children, as it does not involve the use of ionizing radiation. MR imaging with intravenous contrast material can be useful in differentiating tumor from thrombus and distinguishing benign from malignant cardiac masses. MR imaging also can be used to determine the extent of myocardial, pericardial, and coronary invasion, and to provide additional anatomic information for surgical planning. Additional functional data can be provided with MRI as a mobility of the mass and valvular compromise, and these also can be evaluated. So let's go to rhabdomyoma, which is the most common cardiac tumor in both neonates and fetuses. There is a very strong association between cardiac rhabdomyomas and tuberous sclerosis, which is an autosomal dominant disease characterized by benign hamartomas in multiple organ systems. The incidence of tuberous sclerosis in patients with cardiac rhabdomyomas is 60 to 80%. It is very, very high. So every time we see in fetuses a rhabdomyoma, we should always perform an MRI and genetic testing to look for tuberous sclerosis. On the other side, 50% of patients with tuberous sclerosis also have rhabdomyomas. So it is a very high incidence, both sides. Cardiac rhabdomyomas may precede skin lesions such as hypopigmented ash-leaf macules and neuroradiologic findings, which include subependymal nodules and cortical tumors, by months or years. As I said, it is the most common tumor in fetuses, newborns, and infants. It is very well circumscribed, lobular, and it is usually intramyocardial, as we see in this case, which is a really huge rhabdomyoma. It is most of the times intramyocardial, but it can also be intracavitary because it can extend to the cavity, the left ventricular, left atrial cavity. In 70 to 90% of the cases, rhabdomyomas are multiple tumors. We can see more than one rhabdomyomas. And this is actually one of the factors that can lead to the diagnosis in terms of differential diagnosis. If we see multiple tumors, most probably they are rhabdomyomas until proven otherwise. Echocardiographically, they are echo-bright, as we see here, and on MRI, they're iso or hypointense. Usually, which is very good, they regress over time. They present in cases of tuberous sclerosis, sporadically as isolated tumors, but they can coexist with congenital heart disease. We can see here in MRI images a mass, a rhabdomyoma, arising from the lateral wall of the left ventricle and is iso-intense to myocardium on T1 images without fat saturation before and after contrast administration. They are mildly hyperintense on T2 fat-saturated images, and they are iso-intense on late gadolinium enhanced image. Here, so that you can see how often they regress, we see a case of a fetal rhabdomyoma. This was a case without, the fetus did not have tuberous sclerosis. And as we see, there is a singular rhabdomyoma, which is in the left ventricular outflow tract, and it produced left ventricular outflow tract obstruction. After the baby was born, the surgeons really wanted to operate on that baby. The gradient was around 70 to 80 millimeters mercury, but because of the history of rhabdomyomas, the long-term prognosis that is that usually they regress. We waited on that baby, and also the baby did not have any clinical symptoms. So we were able to wait, and I can show you the image of the same patient at 2 years of age, which now shows that the rhabdomyoma has almost completely regressed, and now there is only this subvalvar membrane, which does not cause almost any left ventricular obstruction at all. So this was a very nice case without tuberous sclerosis. But over here, we see a rhabdomyoma in a 37-week gestation fetus with a large intrathoracic mass seen on the ultrasound. The gynecologist saw a huge mass in the ultrasound, and then the baby had an MRI. So fetal MR image demonstrates a large left ventricular mass. FISP image of the brain shows two subependymal nodule in the right lateral ventricle. That infant died of arrhythmia, cardiac failure, and pulmonary hyperplasia 1 day after birth. Autopsy confirmed a large cardiac rhabdomyoma, cortical tumors, and subependymal nodules, findings which are consistent with tuberous sclerosis. The majority of the rhabdomyomas spontaneously regress, as I said before, in early childhood. Surgical resection is reserved only for cases of heart failure due to outflow obstruction or arrhythmias. Recent reports have revealed everolimus, a mammalian target of rapamycin inhibitor, to be a very potential new therapeutic option for treating clinically significant cardiac rhabdomyomas. This is an echo image. This is echo images, but we can see how rhabdomyomas can be multiple and how they can also intrude into the cavities, the left atrium and left ventricle in this case, and could be also pedunculated as pedunculated masses. This particular child had surgery because it was felt that there was some compromise of the mitral valve because of this pedunculated mass, which also was part of a huge rhabdomyoma. The child did very well, and hopefully, because there's no follow-up for this child, it came from another country and left after that, hopefully the rest of the mass regressed over time. Rhabdomyomas also can cause arrhythmias, as in this child that we can see this ventricular, this PVC. And this is a case of fetal rhabdomyomas. This is a fetal image, left atrium, left ventricle, right ventricle, right atrium. And this is an echo-bright mass that we can see in this image that there are multiple masses actually, really echo-bright, and that can be, they are rhabdomyomas that actually obstructed the left ventricular outflow tract and caused secondary cardiomyopathy. As you see, the left ventricle is very big and has function is compromised. The rhabdomyosarcoma is the malignant end of this disease. Both we can see here rhabdomyosarcoma, and you can see that it is very infiltrative in these images. On fat-suppressed T2 images, the mass resulted strongly hyperintense, probably due to its rich vascularization, with possible presence of hemorrhagic components. But post-gadolinium, one can see that it is very highly vascularized, and you can see the infiltrative behavior of the mass with involvement of the papillary muscles. Fortunately, rhabdomyosarcomas, both in children and adults, are very, very rare. So we move to the next most common mass in children, which is a cardiac fibroma. It is usually single, large, located in the lateral wall of the ventricle, of the ventricular septum. It has well defined borders and within the myocardium, and it is a solid tumor with calcification, cystic degeneration, or focal necrosis that may coexist. Echocardiographically, usually has the same echogenicity with myocardium, and at MRI it can be iso or hypointense compared to the myocardium, and the core usually doesn't hold gadolinium. This particular case that you see here, it's a newborn that the fibroma was actually seen like a week or 2 weeks before delivery. You can see here that it is really big in terms of its size. It's like 2/3 of the left ventricle. This patient, I actually follow him up, and he's doing extremely well now. He's almost 8 to 9 years old. He had nothing, absolutely nothing, no surgery, no arrhythmias, no nothing. And the good thing about it is that the tumor remained exactly the same in size, whereas the rest of the heart developed and grew. So now that the child is 8 to 10 years old, it's actually only less than 1/3 of the left ventricle, which is actually really good for in terms of prognosis. They may cause obstruction, valvular distortion, and coronary compression. And they also may decrease in size, as I said, which is unusual, but in this particular case, we were very lucky and we saw that. Fibromas offer unsingle lesions that do not decrease, unlike rhabdomyomas. Therefore, cardiac fibromas generally can be surgically resected if there is a need to do so. Cardiac transplantation is reserved for patients with large tumors that cause progressive heart failure. Pacemaker placement may be required for arrhythmias because arrhythmia is one of the major symptoms with fibromas. Either one can have arrhythmias which can actually deteriorate a lot the long-term prognosis, or as in our patient that has never had any arrhythmia at all. He has been followed up every year with Holter, and likely there was no arrhythmia. As we see here, a fibroma generally is a very well-defined mass that is hypo or iso-intense relative to the myocardium on T1 weighted images and hypo-intense on T2 weighted images, as we see here. At imaging, these tumors may demonstrate slow, progressive, diffuse, or heterogeneous enhancement after administration of intravenous contrast material with a hypointense core due to decreased blood supply that is discernible from the surrounding myocardium. Actually, late enhancement occurs. Here we can see that how bright it is during late enhancement, after gadolinium, late after gadolinium. And this is actually very important for the diagnosis of fibroma. If you see late enhancement, most of the times it's a fibroma until proven otherwise. We can see here the same patient, the one that you saw before, with this large fibroma, which actually now is smaller. See, it's in here. Bright blood images. And as I said before, there is intense enhancement with central hyperintensity in the delayed phase. Fibromas, that occurs because fibromas are a collection of fibroblasts interspersed among large amounts of collagen. Gadolinium diffuses into the interstitial space, but not across cell membranes. And because there is a great extracellular space for gadolinium accumulation in fibromas, and the distribution kinetics are slower than normal myocardium, this phenomena result in delayed and persistently higher relative concentration of gadolinium with late enhancement. The other tumor that we're going to talk about is inflammatory myofibroblastic tumor. It is very rare. It consists of mesenchymal cells composed of differentiated myofibroblasts and numerous inflammatory cells. It arises from the endocardium and may involve the valve leaflets with typically broad-based attachment and lobulated contour. The right atrium and right ventricle are the most common sites of involvement. Hemangioma is a benign vascular tumor. It can be located anywhere in the heart with a minimal predilection for the right atrium and the ventricular septum. May be intramural or endocardial and can present as endocardial nodules 2 to 4 centimeters in size. Microscopically, they are classified as cavernous hemangiomas, capillary hemangiomas, or arteriovenous hemangiomas. They are usually asymptomatic but can present with ventricular tachycardia, high output congestive heart failure, pericardial effusion, cardiac tamponade, hemorrhage, or thrombocytopenia. They can be associated with hemangiomas in other sites like oral cavity, bowel, etc. At MR imaging, hemangiomas are generally heterogeneously iso or hypointense or T1 weight images and hyperintense or T2 images. A heterogeneous appearance with hypointense areas or T2 images has also been described. They typically demonstrate heterogeneous enhancement after administration of intravenous contrast material or AVID enhancement at first pass myocardial perfusion imaging, which is actually different from the late enhancement that we saw in fibromas. These, because they're vascular tumors, they have AVID enhancement almost right away. Differentiating hemangioma from other vascular tumors, such as angiosarcoma or paraganglioma, may be difficult at MR imaging. This is a lipoma. It's a very rare tumor in children. Lipomas mostly arise from the epicardium, but may involve all 3 layers of the myocardium. They are usually solitary, but may be multiple in conjunction with congenital heart disease or tuberous sclerosis, or sometimes they exist sporadically in normal hearts. This is a case of lipoma. The tumor is homogeneous. It has a high signal density. It is hyperintense. There is a loss of signal in fat suppressor sequences, and there is no enhancement with gadolinium. Let's go now to the third most common tumor in children, which is a teratoma. Even though it is extremely rare, it is the third most common tumor after rhabdomyomal fibroma. It is located most of the times in the pericardium, usually attached to the aorta or the main pulmonary artery. It rarely presents with an intracardiac mass arising from atrial or ventricular wall. Most of the time, it arises from the pericardium. It is usually detected by echo as an encapsulated cystic mass, usually located at the right side of the heart. It is associated with large pericardial effusions that may compress vital structures and cause symptoms. The most typical sign of a teratoma is that it has both cystic and solid components with multilobular appearance. And as we see in this case, that we see large pericardial effusion and a teratoma that has many solid and cystic material. It is the second most common primary cardiac tumor in fetuses and neonates. This we can see here an intrapericardial teratoma, cystic and solid material. And this is a case, an MRI case of pericardial teratoma. We can see both cystic and solid materials, huge pericardial effusion, and it's really a large tumor here and a big heart. Usually they don't have very good prognosis, obviously, teratomas. Then we move to a myxoma, which is the most common primary tumor in adults, but it is very rare in children. At MR imaging, myxomas are pedunculated mobile masses with irregular borders, and they are hypointense T1 images and hyperintense T2 images because of their high water content. They may contain foci of fibrosis or hemorrhage. Myxomas typically demonstrate heterogeneous enhancement after administration of intravenous contrast material, although homogeneous enhancement has also been reported. We move to the Purkinje cell tumor, which is very, very rare. It is a cardiac hamartoma. It is described only in infants and children. It has a higher propensity for the left ventricle and the conduction system. And this tumor consists by altered myocytes that are round and resemble histiocytes. They're usually yellowish nodules in the endocardium, epicardium, or the valves. It can cause refractory arrhythmias, and this is the usual presentation, and rarely it is associated with congenital heart disease. So we can move now to malignant cardiac tumors in children. Sarcoma is the most common primary malignant mass. Lymphoma is rare. Usually primary is very rare, and secondary as well. It can be asymptomatic. And then metastatic disease, it is the most common malignant cardiac mass in children. It's commonly metastatic than anything else. This is a primary cardiac sarcoma. Demonstrates enhancing lobulated soft tissue mass at an inferior cavoatrial junction that extends to the right atrium, and finding which is consistent with tumor recurrence. Primary cardiac lymphoma is extremely rare in pediatric population and is defined as lymphoma involving only the heart or the heart and the pericardium. Primary cardiac lymphoma is typically a non-Hodgkin lymphoma. Secondary cardiac involvement by lymphoma, either through direct extension or via hepatogenous spread, is more common than primary cardiac lymphoma, but here is the case of a primary cardiac lymphoma. Now we can move to cardiac tumor mimics, the most common being a thrombus. Intracardiac thrombosis is the most common mimic of the cardiac tumor. It is rare in children compared with adults, mainly because of the low prevalence of myocardial infarction in children, although thrombus may occur in the setting of myocardial infarction in patients with homozygous familial hyperlipidemia or Kawasaki disease. Cardiac thrombi in children are more commonly associated with indwelling central venous catheters. They can also be seen in patients with congenital heart disease or dilated cardiomyopathy. This is a thrombus seen in echo. This is a catheter tip and a thrombus here, as seen in CT and MRI. A pericardial cyst is another cardiac tumor mimic. These cysts are benign and are formed during early development. Patients are usually asymptomatic, totally asymptomatic, but cases of infection or cardiac tamponade have been reported rarely. At MR imaging, they are hyperintense T2 weighted images. Their appearance or T1 images may vary depending on their protein content. Pericardial cysts do not enhance at CT or MR images. Another rare tumor mimic is an aneurysm or a biventricular. It is very, very rare in children, but it can exist. In conclusion, although cardiac tumors are rare in children, an understanding of the common types of benign and malignant pediatric cardiac tumors and their imaging features is very important because of the epidemiology and tumor types that differ from those encountered in adults. So, as a conclusion, as a take-home message is that in infants and children, the most common cardiac tumors are rhabdomyomas and fibromas, which are benign but can compromise cardiac function depending on the size and location. Myxoma and thrombus uncommonly occur in children, but they are the most common primary cardiac tumor and cardiac mass mimic, respectively, in adults. As in adults, malignant pediatric cardiac tumors include sarcoma and metastatic disease. Imaging plays a very important role in characterization and diagnosis of these cardiac tumors, as well as in guiding patient management, and can be used to assess disease extent and cardiac function, and of course, prognosis. Thank you.
Thank you very much, Dr. Laskari. Very nice presentation, very interesting cases, comprehensive presentation. Very interesting for me. I'm an adult cardiologist. I don't know if we have any questions from chat. I can't see anything. I have one question for you. How reliably you find cardiac MRI in distinguishing benign from malignant tumors in children, from your experience?
Well, I think, the cases are very, very rare. And most of the times the tumors are benign. But of course, obviously, it is very helpful because a malignant tumor, as I said before, is very vascularized, and one can differentiate that with MRI much better, a lot better than echo. I think it is very helpful in distinguishing the two most common benign tumors, fibrorhabdomyoma, which is very, very, if you see a tumor, just, by percentage, it has to be a rhabdomyoma until proven otherwise. But it is very, very helpful in distinguishing rhabdomyomas from fibromas, which are the most common benign tumors. And I think MRI is very, very helpful, almost pathognomonic, almost pathognomonic in differentiating these two types of tumors.
Thank you very much. Do you use mapping techniques for a characterization of the masses? For example, for lipoma, can give an answer. I mean, you will have low native T1, and it will be homogeneous.
Yeah,
but use mapping techniques.
We do, but actually, I gather all these images from, they're so rare that we see like one kid in like 3 years, something like that.
Okay.
I don't know how often. I mean, you're in Britain. How often you?
Well, as I said, I'm adult cardiologist. Of course, we collaborate with pediatrics. I assume they're more often than in Greece due to the population size, but still they are rare, quite rare.
Mm-hmm. Thank you.
Okay. So, Sophie, would you like to present the next?
Go ahead. I will comment if it needs. You perform very well. I enjoy.
Thank you. So, would you like to present the next presenter, the next colleague, or I can do it, or Dr. Laskari? I don't mind.
Yeah, Dr. Laskari.